think that's used too often. So what metals are used? Stainless steel, tantalum, and nitinol. Coronary artery bypass grafting, abbreviated to CABG. So, traditional CABG. I would know the numbers for each. I mean, that's really how you can define them. So, traditional CABG is up to 5 arteries are bypassed. All right, and that makes sense. We have clogs in those coronary arteries. We're not getting the blood to the heart muscle where it needs to be, so we need to go past this clog and put blood there. All right, so we can do up to 5 coronary arteries bypass with traditional CABG, but like this is super invasive. You usually like cut that person open. You completely render their heart unusable during that time, which means they need to be on ECMO, and it's really expensive, obviously. So let's talk about off cab, which is off pump. I mean, already that should trigger something. Let's see, we're off pump, which means we're probably doing slightly less to the heart because it doesn't need all the support. Yes, up to 4 arteries to be bypassed. It's still pretty invasive. You still have a huge gas in your chest, but you don't need ECMO. It costs 25% less than classic cabbage. So, mid-cab. This is minimally invasive direct coronary artery bypass. We like minimally invasive. So usually a good thing. So 1 to 2 arteries are bypassed. This is minimally invasive. Costs about 4% less than classic CABG. And the internal memory artery, the IMA, is used for the graft. All right. So just so this is a great diagram. If you're a little confused at like what these processes actually are, this will clear this up. So it's directly in your slides. Just copy and paste it. You can find it. Makes sense. Alright, ECMO. I mentioned it, you might know what it is. ECMO is usually a last resort. If you can avoid using it, you should avoid using it, and you will avoid using it. So it stands for extracorporeal membrane oxygenation. I think it's the same thing as the external heart-lung machine. There might be some slight differences. So yeah, so basically, you're cutting your chest open and you're futzing with your heart, and you're sewing things together, and you're cutting things up. Your heart can't really do its job while this is happening. So basically, you take all of the deoxygenated blood, send it through a huge tube into this machine. It does its thing. It becomes oxygenated. Simple enough. It has many negative effects in the body. It's used in CABG. It's not used in off cab. Remember, off pump, and it's not used in mid cab because it's minimally invasive, and you're only really doing 1 to 2 arteries at a time. And as far as off cab, yeah, you're off the pump, but you're still doing up to 4 things. So this heart's going nuts in your chest cavity, just beating all over the place. So you're gonna have a hard time sewing in these tiny little vessels and so on. So it requires positioning and stabilization of the heart. We talk about this a lot. We're not gonna talk about it a lot. So mid cab is minimally invasive. There's no pump. There's no slowing of the heart, and there's no massive incision. All right. Next, 2. Biotechnology and cardiovascular system. So we're going to talk about valves, right? Cardiac valves. So valves have one job, a single job. And you have important types of the pulmonary, the aortic, the mitral, and the tricuspid. We focus mostly on the aortic valve. We'll talk a little bit about the mitral valve, but it's mostly aortic. So the one job of valves is to ensure the unidirectional flow of blood, right? Make sense? You pump it out, you don't want it to come back in. When this fails, when the cardiac valves fail to do their job, it's called insufficiency, and this results in the backflow of blood. So, why does this happen? So, why would all of a sudden your valves just stop working? So disease can lead to stenosis, and we all know what stenosis is. It's the hardening, it's the stiffening of things, usually aortic. So, why does this matter? Well, your valves, they're flexible, right? They're just tissue, so they work like this. They open all the way and they close all the way, right? So if something is stenotic or hardened, it's not flexible. We discussed this already. So what it probably does if you have a stenotic valve is opens, but really can't really close. Can't really open, can't really close. So it's not moving much. You can have congenital issues, like just born with bad valves. Rheumatic aortic valve disease. You can get rheumatic fever if you get a freak incident with strep, which is why you should always get tested for strep and take your medication. You don't want this. And then you can have calcific aortic stenosis, and this is just for some reason your body thinks it's okay to deposit calcium at your valves. So, solution, when your valve's not working, usually we replace the valve. We have a little bit of a exception later with the mitral cleft, but we'll talk about that later. So let's talk about valve replacements. And because we're, just to orient yourselves, we're most talking about the aortic valve. Technically the aortic cannula, you can abbreviate it to the aortic. So, implantation. You don't really need to know too much about it, but I wanted to give you a brief overview. Here it is. Here's how it works. You cut the patient open, get rid of that nasty valve. You determine how big the hole is, so you know what kind of valve to put in. You have like a shelf of different types of sizing of valves, and you pick the one that's the right size, and then you put it in there. And it's really complicated, and it uses a lot of string and stuff. So, implantation, a little more. So, with the aortic valves, which are the ones we're talking about, we use transapical implantation with these valves. So let's just look at this slide a little bit. So transapical means the apex of the heart is this lovely point right here. So transapical means you're crossing the apex, so you're just kind of shoving it through the point of the heart, which is on the bottom. So transapical implantation for these types of valves. Now what do I mean by these types of valves? You know, based on what we know, what do these look like? These should look like something familiar to you guys. They look like stents, right? You got that metal cage thing going on? Yeah, so these are stented valves. So when you're putting in stented valves, you want to use transapical implantation. Okay, questions on that? If you couldn't recognize that those look kind of like stents, you should review your pictures or whatever you're doing. Okay, so we determined that you can have disease valves, you can replace disease valves. What type of valves are these replacements? What are these replacements? What are your options? You can do mechanical or tissue. Well, how do you determine this? Based on what the patient needs, their parameters, how old they are, what other drugs they're taking. There's a ton of stuff. Not important. You know that not every valve will suit every person. So let's talk about mechanical valves. The pros of these, I mean, they're durable, right? They can stand blood hitting it all the time. Which, you have a piece of metal and you throw blood at it at a high pressure, it's fine. And these things are super durable. They can last a lifetime, essentially. So why doesn't everyone use these? Pretty big con. So when your blood touches most metals, it gets upset and might clot. So if you have these clots, we talked about clots before, they'll break off, they'll travel through your bloodstream, and they'll cut off circulation somewhere and you'll lose blood. Right? We don't like that. So you have to take anticoagulants for the rest of your life. The most common anticoagulant is sodium warfarin, but just know that you have to take these for the rest of your life, and that's very unappealing to some people. Because you cut yourself, you get a bad scrape, you can't really clot your blood well, you're in danger with a lot of minimal risk injuries. So, tissue valves. Now, within tissue valves, you have different types. You have xenografts, xenophorin, so from some other animal. You can have paper cow, allografts, same species, from cadaver. Cool thing about this is no immunosuppression is required, right? When we talked about transplants before, we be on this cocktail of immunosuppressants, but not if you get an allograft valve. It's preserved in liquid nitrogen, so it's not an immediate, this person's dead. When you take their valve out, you get someone else, you freeze them, and you put them away somewhere. And autografts from yourself, but this is the Ross procedure. It's really, you'll see, it's confusing. You don't need to know it, just know that autografts exist. So, tissue valves, once again, seem great. What do we do about this? So what problems? Calcification. Tissue, even if it's not your own, even if you put a pig valve in, you're still at risk for calcification, right? Because your cells in your body can decide they want to deposit calcium there from whatever signaling pathway, and that can happen with tissues. And then you're just back at stage 1. And tissues wear down. If you throw blood at tissue at a high enough pressure, it's going to start to break down. So it's not as strong or as long lasting as metal. It usually lasts about 10 to 15 years, which means it's given to older people. So this, you guys have to, it's pretty complicated, right? You get to memorize this? You know each step? No. Okay. Okay, so let's talk about article a little bit. The MitraClip article. MitraClip is just a brand name for a general idea of a mitral clip. So what does this address? Mitral regurgitation in a percutaneous, we know what that means, non-surgical way. So therefore, it's not technically a surgery, it's not technically done in the OR, it's done in this catheterization lab. This is a case of valve repair versus valve replacements, and obviously that's preferred. You don't really want to cut something out and remove it unless you have to. So you'd rather just fix it. So lower rates of medical device issues. How this works is you go up through the vena cava, cross the heart, right? So your vena cava on your right side, you go up through that with the catheter, you cross through the heart, which means you need transseptal puncture. That's just that part of it. Case selection is the most important determinant of success for this procedure. Not everyone can get this. Not everyone whose mitral valve isn't working can get this. So you have to be able to pick and choose your patients to see who is able to benefit from this procedure. Is the patient anatomically suitable? Do they have the proper degree of mitral regurgitation? These are things they have to look at. How do you look at these things, How do you look at these things as you're going in there with the catheter? We're not opening the person up. That's the great thing about this. Minimally invasive. So you have to use 3D transesophageal echocardiography. They abbreviate it TEE in the article if you're confused. Transesophageal through the esophagus, through the throat. Okay. So I reread that article. It's not that bad. Any questions on that? Just a little note. This exam is fewer multiple choice and more fill-ins than the last two exams, so be on your toes. Questions?